Welcome to this module on transfusion medicine in an urgent care setting. Transfusion medicine is actually one of my favorite topics, but I know it can feel a bit daunting at times. How many blood types are there again? When do I transfuse my patient? This module will hopefully help answer some of those questions and a few more. Let's get started. Welcome to the Master Course on Urgent Care, brought to you by KRUUSE. We're going to start by going back to some basics. Let's talk about blood types. Traditional canine blood group classification is focused on the dog erythrocyte antigen system, or DEA, followed by a number denoting blood type. Recently, there have also been discoveries of the other canine red blood cell antigens, such as DAL and Chi 1 and 2, that do not follow the DEA system. In addition, where the DEA system used to classify blood types as a 3-factor, 4-phenotype system with DEA 1.1, 1.2, 1.3, and null, it is now known that 1.1, 1.2, and 1.3 were all the same epitope with different surface expressions. Since then, we have reverted to DEA 1 negative or weakly to strongly positive. DEA 1 is extremely antigenic, and therefore it's the most clinically relevant blood group. Naturally occurring anti-DEA 1 alloantibodies do not exist in DEA 1 negative dogs. Therefore, they are considered universal donors. But sensitization can occur. DEA positive blood given to a negative dog will lead to the development of agglutinating and hemolyzing antibodies in 3 to 5 days. There is a positive breed predilection in St. Bernards and a negative breed predilection in Boxers, GSDs, Dobermans, and Greyhounds. Of the DEA 3, 4, 5, and 7 groups, positive is the dominant phenotype, with 6 to 7% of dogs in the US being DEA 3 positive, and a higher prevalence existing in Greyhounds. 99% of dogs are DEA 4 positive, therefore these can also sometimes be used as universal donors. The prevalence of DEA 5 is approximately 11% in the general canine population, with Greyhounds being overrepresented. Typing sera are no longer available for DEA 6 and 8. But wait, if you thought 8 was a lot, there are actually greater than 12 blood groups. These are just the most common ones listed and studied, and we're not going to go into all of the others. The DAL antigen group was recognized in 2007 when a Dalmatian developed anti-DAL alloantibodies after a transfusion. The prevalence of the DAL antigen is high, so about 93% of dogs are positive. DAL negative dogs are overrepresented in Dalmatians, Dobies, Shih Tzus, Lhasa Apsos, Beagles, and Bichons. However, naturally occurring anti-DAL alloantibodies have not been identified. Another blood group, called the Chi blood group, was originally ID'd in South Korea in 2016. The prevalence of Chi 1 and 2 was 94% Chi 1 positive and Chi 2 negative. There are no anti-Chi alloantibodies that have been discovered. Feline blood groups are a little bit more simplified. They are classified using an AB group with 3 alleles, A positive, B positive, and AB positive in decreasing order of frequency. Greater than 95% of domestic short-hair and long-hair cats in the US are type A, followed by B, then extremely rarely type AB. Approximately 50% of Turkish Vans, Devon Rexes, and British short-hair cats are type B. Clinically significant occurring alloantibodies do exist in type A and B cats, but not AB cats. Type A cats can have no or weak anti-B alloantibodies of both IgG and IgM origin, leading to agglutination and hemolysis. Type B cats have strong, predominantly IgM anti-A alloantibodies, which can result in severe agglutination, acute hemolytic transfusion reactions, and neonatal isoerythrolysis. A feline red blood cell antigen called MYC was identified in 2007, but is not considered clinically significant at this time. When considering blood product transfusion, it is important to know how to pursue pre-compatibility testing to ensure that the transfusion is as safe as possible. This can include blood group typing, antibody screening and identification, and cross-matching. Blood typing detects hemagglutination of red blood cells with known red blood cell antibody to determine blood type. Typing should be determined for both donors and recipients to ensure compatibility and increase the likelihood of red blood cell survival post-transfusion and to avoid sensitization. DEA1 blood group is the most immunogenic and clinically significant for dogs. Since cats possess naturally occurring alloantibodies, patients should be type compatible for both red blood cell and plasma product transfusion. There are several options for blood typing. The first is the gel column test. It's the gold standard in veterinary medicine. The second is immunochromatographic testing, and it's performed by migration of red blood cells onto a strip coated in antibodies, and antigen binding determines the blood type. It's not affected by autoagglutination as only free red blood cells migrate up the strips. It is, however, affected by cold agglutination, in which case you can heat the strips up to try and stop it. Cold agglutination means that the blood is agglutinating outside of the body. Immunochromatographic testing is also affected by icterus or hyperbilirubinemia, and the cells should be washed 3 times prior to performing the testing. Cell washing is done by placing 3 drops of a buffer with 5 microliters of red blood cells, centrifuging them, and then pouring off the supernatant and performing this 3 times over. Agglutination cards can also be used to determine blood typing. These are point of care, and the cards are able to be stored at room temperature. A card is coated with a lyophilized reagent on the patient area that is reconstituted with a phosphate buffered saline. You look for autoagglutination in the patient well to determine blood type after the application of blood to the wells. It's 89% accurate unless autoagglutination is present. Once your patient is typed, you then need to cross-match the blood to determine patient and donor compatibility. This includes major and minor cross-match testing. Major cross-match tests compatibility between the donor red blood cells and recipient plasma or recipient antibodies, while the minor cross-match tests the compatibility between the donor plasma or antibodies and the recipient red blood cells. A positive test shows visible hemolysis and or agglutination consistent with incompatibility, while a negative test is void of these signs. Given the lack of evidence of acute hemolytic transfusion reactions in dogs receiving first-time transfusions, the utility of a cross-match in dogs prior to their first transfusion is debated. A study in 2017 showed the incidence of incompatibility cross-match in a transfusion-naive group of dogs to be 17%, or about 25 out of 149 dogs. Cats should always be cross-matched due to their naturally occurring alloantibodies. Fun fact, pregnancy does not induce alloantibody formation in dogs, therefore no additional pre-transfusion compatibility testing other than blood typing is necessary. This is not the case for cats. Cross-matching is also necessary in dogs and cats that have been previously transfused and have had an appropriate time lapse for alloantibody formation. In dogs given transfusions greater than or equal to 4 days prior, it's necessary to determine cross-match compatibility. Techniques for cross-matching are becoming increased and more varied. We will briefly discuss the 2 most common cross-matching tests that are currently available. This consists of an agglutination test like the gel column test, which are standardized, relatively fast, and easy. They use microtubes that contain a preloaded dextran acrylamide gel that acts as a sieve. We place a measured amount of recipient serum and donor red blood cells into the reaction chamber, or the upper part of the column, and then we centrifuge it. Compatible red blood cells move throughout the gel to the bottom of the column. Incompatible red blood cells form agglutinates and remain suspended inside of the gel. That indicates a negative test. The main con is that these tests are not as accurate in patients with autoagglutination diseases like patients with immune-mediated hemolytic anemia. Due to this, immunochromatographic testing is becoming more favorable. These tests rely on migration of red blood cells along a membrane so that autoagglutination does not affect the results, as only free red blood cells move. This is similar to the blood typing test that we talked about previously. They are also considered easy but do take a few more steps than the standard agglutination gel column test. The decision to transfuse an anemic patient is based on how the patient responds to the anemia physiologically, including evaluation of parameters such as heart rate, respiratory rate, and blood pressure. The risk versus benefit of transfusion administration must always be weighed appropriately. For example, patients with chronic anemia, like cats with chronic kidney disease, can tolerate much lower circulating tissue oxygen levels and red blood cells than those without. However, a patient that has an acute bleed is not going to be able to tolerate the same level of drop PCV. The type of blood product to be administered is also based on the patient's clinical history, current volume status, and the absence or presence of other coagulopathies. To determine the volume needed for a transfusion, you can use formulas like the following. The volume of packed red blood cell to be delivered equals the PCV percentage rise desired times 1.5 times the body weight in kilograms. Or, if you're using whole blood, you can roughly equilibrate 2 mils of whole blood per kilogram will equal a PCV rise by 1%. Once your patient is typed appropriately and your sample is cross-match negative, you can move forward with your transfusion. Now we start the process of monitoring to look for transfusion reactions. Let's talk about the different transfusion reactions that can occur and how they happen. The incidence of transfusion reactions in large retrospective veterinary studies has ranged from 3.3% to 28% in dogs and cats. Acute reactions are defined as a reaction within 24 hours of the transfusion completion, while a delayed reaction is defined as greater than 24 hours after transfusion completion. Transfusion reactions can also be defined based on their cause and are divided into immunologic and non-immunologic categories. For immunologic reactions, febrile non-hemolytic reactions are the most common and are related to the presence of white blood cells in blood products. Clinical signs can be as mild as urticaria or as extreme as anaphylaxis. Other immunologic reactions include acute hemolytic reactions or delayed hemolytic reactions. This happens when antibodies in the patient react with red blood cell surface antigens of the donor. These can be IgG or IgM antibodies that activate the complement system and form a membrane attack complex that causes damage to the lipid bilayer of the red blood cell membrane. Antibodies and complement fragments also increase phagocytosis of newly transfused red blood cells, so they break down much more quickly. During a hemolytic reaction, you also get release of inflammatory cytokines such as IL-1, TNF-alpha, IL-6, IL-8, complement, nitric oxide, endothelin, and they all exacerbate this process. Clinical signs can include fever, restlessness, hypersalivation, incontinence, vomiting, shock, hypotension, and possibly acute death. Plasma and urine hemoglobin levels increase within minutes of the reaction occurring, and incompatible cells are removed within a couple of hours. Transfusion reactions can then further be classified as non-immunologic. This can be secondary to infectious disease transmission through donor blood, leading to systemic infection and sometimes sepsis, citrate toxicity, leading to calcium chelation and hypocalcemia, transfusion-associated circulatory overload, or TACO, which can manifest as heart failure, hypothermia secondary to administration of cold blood products or room temperature blood products, vomiting, mechanical hemolysis of new red blood cells, and pulmonary complications like transfusion-related acute lung injury secondary to immune complex formation. Reactions can be mild, moderate, and severe. In mild reactions, like any hypersensitivity reaction, we can have mild febrile non-hemolytic reactions occurring. We can have some fever, urticaria, some facial edema. If we see a mild reaction, we typically stop the transfusion for a short period of time and restart it at a slower rate. A mild hypersensitivity reaction can manifest as a cutaneous reaction with hives. We can administer diphenhydramine or antihistamine in these patients. Moderate reactions can be both hemolytic and non-hemolytic. They can include fever, tachycardia, tachypnea, and weakness. You don't necessarily have histamine release, and therefore diphenhydramine and antihistamines are unlikely to help. Glucocorticoids are unlikely to help acutely, but could prevent a delayed reaction from occurring. So we've talked about mild and moderate transfusion reactions. Let's talk about the worst of the worst, the severe reactions. This can include things like anaphylactic shock, which manifests as severe tachypnea and hypotensive collapse. In these patients, we have to treat immediately with epinephrine and fluid therapy. In cats, because their anaphylactic reaction typically occurs in the lungs, we also want to consider the administration of bronchodilators. This is most common in B cats that receive A blood due to the marked number of alloantibodies that B cats inherently possess. We have rapid and severe hemolysis often seen with these severe reactions. We should do serial PCV and urine color monitoring to look for presence of rapid drop in red blood cell counts, as well as hemoglobinuria and myoglobinuria suggesting kidney injury. We also will want to culture and do a cytology of the blood bag from the donor blood. Transfusion reactions can potentially be delayed and can sometimes, unfortunately and scarily, manifest weeks to months later. This can look like acute liver injury, anorexia, fever, lethargy, and listlessness. We want to review the patient's history closely and see when the last time they had a transfusion was. Treatments to consider for transfusion reactions include steroids for acute hemolytic reactions. If urticaria is seen, we can give diphenhydramine and possibly steroids. If we have hypocalcemia from calcium chelation, we'll want to give calcium supplementation. We can also see hypomagnesemia and can supplement with magnesium sulfate. Hypomagnesemia or low magnesium can be a little bit trickier to diagnose unless you have the capacity to check an ionized magnesium in hospital. If you have a patient that has had a historic transfusion, or if you have a patient receiving a transfusion in hospital with a suspected reaction, and they develop ventricular arrhythmias, that could potentially be a marker for magnesium deficiency, and you can consider magnesium sulfate in these patients. Hyperkalemia can also occur due to electrolyte shifts like calcium when we have multiple transfusions. If hyperkalemia is very severe, it can cause cardiac changes, particularly manifesting as bradyarrhythmias. In these cases, we may want to consider administration of calcium gluconate to help with the cardiac changes, followed by insulin and dextrose administration to actually bring the potassium back down. In patients that develop circulatory overload, which, like I said, can manifest as heart failure, we might want to consider giving them a diuretic like furosemide and possibly nitroglycerin paste, particularly if they're exhibiting signs of severe hypertension. We can also develop dilutional coagulopathies, unfortunately. In that case, these patients need fresh frozen plasma to give them back their coagulation factors so they can start clotting their blood again. Finally, we'll talk about monitoring of patients during a transfusion to make sure we don't see any signs of these transfusion reactions. For any patient that is receiving a transfusion, we want to perform a baseline temperature, pulse, and respiratory rate, evaluate the pulse quality, mucous membrane color, and CRT. We want to perform a cardiopulmonary auscultation, check a blood pressure, and even consider checking a pulse ox. We then recheck most of these things at 5 minutes after the start, and then every 15 minutes for 1 hour, and then hourly until the transfusion ends. Most transfusions are going to be administered over a 3 to 4 hour period of time. However, if you have a patient who needs a large volume of blood rapidly due to decompensation, you might not have the option of starting your transfusion slowly. If that's the case, you stay with that patient and monitor them as closely as possible to see if they are developing any signs associated with the transfusion reaction. You have reached the end of this module on transfusion medicine in an urgent care setting. Please proceed to the next module when you're ready, or if you have completed all of the modules, please go ahead and take your quiz so you can receive your credit. Thanks for joining us.